Greetings. Today we're going to be doing the ears, nose, throat, or the ENT exam. And the first thing you should always do when approaching a patient is introduce yourself. Hi, Steve.
Hi.
My name's Beverly. I'm a physician assistant who's going to be doing your ears, nose, throat exam today. And then the next thing I like to do is either wash your hands if you have a sink or use hand sanitizer to get your hands clean on the exam. So as I had mentioned, we're doing ears, nose, throat, and I'm going to be doing the exam in that order. Ears, nose, and then throat. And the first thing that I'm going to do with the ears is I'm going to inspect. I'm going to be looking at the external ear and the mastoid area. I'm going to be looking at size and shape and symmetry and landmarks. I'm going to be looking at the color, position, deformities, and any lesions. And then after that, I'm also going to be palpating these areas, the external ear and the mastoid area, for tenderness, swelling, and for any nodules. So I'm just going to have you turn your head for the exam's sake. So looking at the external ear, the helix, the tragus, the earlobe. I'm looking for any abnormalities or lesions. I also want to look behind the ear, the mastoid area. After inspection, I'm going to palpate if there's any tenderness. If there's outside ear infection, sometimes you can have tragus tenderness. Skin cancer is a common place on the top of the ears, especially the non-melanomas. And then also palpating behind the ear and even palpating on that mastoid process. Any tenderness on this side, Steve?
No, none at all.
Good. Then I'm going to come and do the same thing on this side. Again, turn for the camera. Again, looking and inspecting the external ear, looking for any abnormalities. And then I'm going to be palpating it. Again, inspecting and palpating behind it. Good. Any tenderness at all in this area?
No.
Good. The next part of the exam is I'm going to be using an otoscope to look inside the ear. And what I'm going to be looking at is the ear canals and the tympanic membrane. But a couple of notes on the otoscope, it's a light, and you can either make it brighter or dim. And you're going to want it as bright as possible to look in the dark areas of the ear canal and also when we do the mouth exam. The speculum then, you can put on the top and you twist it counterclockwise until it kind of clicks into place. And then you're set to go. So again, I'm going to be looking at the canals. I'm going to be looking for cerumen, for any discharge, for the color, for any foreign bodies or any lesions in the ear canal. I'm also going to be looking at the tympanic membranes, and I'm going to be looking for landmarks like the ear bones, the small ear bones, and the cone of light. I'm going to be looking at the color. Usually it's a pearly gray or almost like a transparent shower curtain. I'm going to be looking at the contour, whether it's bulging out or whether it's retracted. I'm going to be looking for perforations or any scarring on the eardrum. And then also for mobility, which we won't be testing today, but a lot of times to test mobility of the eardrum, you have an insufflator, which is like a rubber bulb that hooks on with a small tube that while you're doing the exam, you gently squeeze it to push air back and forth to see if the eardrum moves. We will not be doing that today. So for exam, what I'm going to do is the ear canal is actually angled anterior. So I'm going to just tilt you a little bit here. I'm going to pull Steve's ear, external ear up and out a little bit, and I'm going to angle in to take a look. And you want to be careful not to be scraping the ear canal because it's a very sensitive area. Another thing to make note of is to brace. For example, especially if you have a child who maybe doesn't want to sit as still as Steve does for ear exams, you want to learn how to brace your otoscope so it moves when the patient moves. So for example, you can brace by using your hands this way. So when Steve moves, my otoscope will move with them. The other way is using it almost as a pencil. You can go this way and brace. So again, bracing your fingers against the head helps. That should Steve move, my otoscope is going to move with them. And then to examine the other side, you're going to want to keep the cord behind the patient. And again, so I'm going to pull up and look in and examining. So that is using the otoscope. Next thing we want to do after using the otoscope is we want to test hearing acuity. And that can be done in two different ways. One way is called the whisper test, where you whisper at least a word with 2 syllables. And then the other way is by just rubbing your fingers in front of the eardrum. So for the whisper test, I'm going to ask Steve to block his left ear while I whisper in his right ear. Cupcake.
Cupcake.
Good. And then I'm going to have you block that ear again. And this would be, can you hear that?
Mm-hmm.
Tell me when it stops.
Stopped.
Good. And then if I come over on this side, I'm going to have you block your right ear. Cowboy.
Cowboy.
Good. You only have to do one or the other. You do not have to do both. But for this video, I wanted to show you both techniques. Now, in the event that there is a hearing loss that you discover, there's 2 advanced ENT testing techniques we can do to help explore that further. It's called the Weber and the Rene test. And these are done by utilizing a tuning fork. And what we do, for example, with the Weber test is I'm going to strike the tuning fork, I'm going to place it on top of Steve's head, either on the very top or on the forehead. And I'm going to ask him if the sound lateralizes to both sides or to the right or to the left. So, Steve, I'm going to...
Both sides.
Good. Both sides would be what you would expect with a normal hearing pattern. Now, if Steve had a hearing loss in his right ear, and if it was due to a conductive hearing loss, like for example, cerumen impaction or a scarred eardrum, when we did the Weber test, if he had a conductive hearing loss, it would actually lateralize to the ear that's affected. So it would lateralize to the right ear, if this is the ear that has the hearing loss. Again, if Steve has a hearing loss in the right ear, and I do the Weber test, and it lateralizes to the unaffected ear that does not have hearing loss, so it lateralizes to the good ear, what that tells me is he has sensory neural loss, hearing loss in the right ear. The other type of advanced ENT testing, hearing testing we do is the Rene test. Again, we use a tuning fork. And what I'm going to do is I'm going to strike it and place it on his mastoid process. And then I'm going to ask him to tell me when he no longer hears it. I'm going to move it to the front of his ear, and he's going to tell me whether he hears it or not. I'm just going to turn you a little bit. So I'm going to strike the tuning fork. Tell me when you no longer hear it.
No.
And can you still hear it?
Yes.
Okay. So that would be considered a normal Rene's test in which air conduction is greater than bone conduction. That's what you would expect. Now, if we did the Rene test, and if Steve said he can no longer hear it, and I move it in front of his ear and he doesn't hear anything, what that tells me is that he has a conductive hearing loss in this ear. So bone conduction is greater than air conduction. So that would be a conductive hearing loss in his right ear. Now with a sensory neuro test, often what you get with the Rene test is they will be able to do until they stop hearing it. You place it in front of the ear. They can still hear it, so air conduction is greater than bone conduction, but not as much as they would hear in the unaffected ear. So that's the Weber and Rene test, which is advanced testing for the ear. And this is what you would do if you elicit a hearing test. Now, we're going to go on to doing the nose exam. So what I like to do is inspect first the external nose. I'm looking for size, shape, color, nostrils, symmetry, and then I'll palpate the nose, the external part, for tenderness, for masses, for any discrepancy. So again, I'm looking, And I'm actually just going to turn him towards me for this video. Again, I'm looking for symmetry. I'm looking for any abnormalities, any deviation. I'm going to have him lift his head up a little bit. I'm going to be looking at the nostrils and the outside. And then I'm going to be palpating any tenderness through this at all.
No.
No, nothing along here. Good. All right. The next part is I'm actually going to test for patency of the nostrils. So I'm going to ask Steve to plug one of his nostrils. Breathe in. Good. And he can breathe out. And then he's going to ask him to do it with the other side too, testing patency. Good. All right. The next part of the exam is I'm going to inspect the mucosa and the turbinates and the septum on the inside of the nose. I'm looking for color, I'm looking for alignment, I'm looking for any discharge, I'm looking for any swelling, for any perforation, for any foreign bodies. So again, I'm going to make the light as bright as possible. I'm going to have him lift his head slightly, and then I'm actually even going to help lift the tip of his nose and look on in. And same thing over here. Good. And you want to be careful not to scrape the septum. It's a very sensitive part of the nose that can be uncomfortable for the patient in the event that you scrape the septum of the nose. And then the last part of the nasal exam is we're going to palpate the sinuses. We're going to do the frontal and the maxillary, and we're going to be palpating for tenderness or for swelling. So, thank you. Any tenderness up here in the frontal sinus area?
No.
Good. And how about down here in the maxillary?
No.
Good. And that concludes the nose part of the ENT exam. So the next part of the exam is the mouth and the pharynx. And so again, I'm going to be inspecting and then eventually palpating some of the places. So I'm going to be inspecting first the outside of the mouth, like the lips and around the mouth, and then on the inside, I'm looking for symmetry and for color, for any swelling or edema. I'm looking for any lesions. Again, around the mouth and the lips is a common place for some skin cancers. I'm looking for any abnormalities. I'll be palpating for any tenderness, for any ulcerations, and then when I look at the teeth, I'm going to be looking for any caries or occlusion, any loose or missing teeth. And so again, some of the structures specifically that I'm going to be looking at, again, is the lips, and then when we go inside the mouth, I'm going to be looking at the buccal mucosa, the gingiva or the gums, the hard and soft palate on the top of his mouth. I'm going to be looking at the anterior and the posterior pillars. Again, the floor of the mouth, I'm going to be looking at that. The uvula and the soft palate, I'm going to ask Steve to say ah to see that elevate, testing cranial nerves 9 and 10, but I'm going to be listening for equal phonation. I'm also going to be looking at the tonsils, the posterior pharynx, the teeth, the tongue. I'm going to be looking for any fasciculations, the strength of the tongue. I'll have him move it side to side, testing cranial nerve 12. I'm going to, part of the oral exam is also doing a gag reflex, and you do that by taking your tongue blade and touching the back of his throat, but we're not going to do that today, but that will be part of your exam, and you're going to want to state that you're doing the gag reflex, testing cranial nerves 9 and 10. And then at the very end, I'm going to put on a glove, and we're going to palpate around the mucosal area. So for the mouth exam, again, the oral pharynx, part of it is just looking on the outside, looking at the lips, looking for symmetry, any swelling, any lesions that I'm concerned about. The other part of the oral pharynx exam is you want to have a good light and then a tongue blade. And for your tongue blade, you're going to want to make sure that when you open it, there's going to be one end that you touch, and the other end is what goes in the patient's mouth. So you want to be careful not to touch that part and just touch the one end. So Steve, I'm going to have you open up for me. Good. And say ah.
Ah.
And if I can't get a good look at the back of the mouth, I'm going to use my tongue blade to help push the tongue down to get a better look. And this way, I can now use my tongue blade to help look around and help move the cheeks around so I can get better look underneath. Again, looking at all the structures. Good. And if there's any teeth that I'm concerned about, I can tap on them for any tenderness. Look up under this side. Oops, good. And then also, I'm going to have Steve stick his tongue out at me. Good. And move it side to side. Good. Again, testing the cranial nerves. And then the last part, again, this would be where I'd want to do the gag reflex if I was going to do it, where you would just touch the back of the throat with your tongue blade. And then the last part of the oral pharynx exam is you're going to want to put on a glove. And you're going to let the patient know that I'm going to be palpating inside your mouth with the glove. Warn them it doesn't taste all that great. I'm going to have you open up gently. Good. And this is where, especially if I have any concerns of any lesions or abscesses, to see if there's any concerns up in that area. Good. All right. And this concludes our ENT exam.